My name is Eric Armbrecht. I'll be the chair of the Midwest CEPAC meeting today. It's an honor to convene this meeting and get started. First order of business is the introduction of the CEPAC members, and as well as our clinical experts and patient partners today. So we'll go around the table, ask each one of the CEPAC members to introduce themselves and confirm your statement of conflict of interest. So we'll start. My name is Eric Armbrecht. I'm from St. Louis University, the Center for Health Outcomes Research in the School of Medicine. I have no conflicts of interest.
I'm Don Casey, physician. I work for a company called MedDecision, which is a technology company. I have academic appointments at both Rush in Chicago and Jefferson College of Population Health, and I have no conflicts that are relevant to this discussion.
My name is Jill Johnson, and I'm a pharmacist and a professor at the University of Arkansas for Medical Sciences College of Pharmacy, and I also have no conflicts.
My name is Rachel Sachs. I'm a law professor at FSU in St. Louis, and I also have no conflicts to discuss.
My name is Ryan Barker. I'm the Vice President of Health Policy with the Missouri Foundation for Health here in St. Louis, and I have no conflicts to report.
Hi, I'm Bill Moore. I am the principal at the strategy group in Kansas City, and I have no conflicts of interest to report.
Hi, my name is Shumei Yun. I'm the Director of Research and Statistics for the Missouri Department of Mental Health. And my view is only my personal view, cannot represent the Department of Mental Health. There is no conflict of interest.
Good morning, my name is Scott Misek. I'm from the St. Louis College of Pharmacy, clinical practice at Barnes Jewish Hospital, and I'm also the Director of Outcomes Research at the college. I have no conflicts to disclose.
Good morning, I'm Rena Conti. I'm an Associate Professor of Health Policy and Economics at the University of Chicago, and I have no conflicts of interest to disclose.
Thank you. We'll move over to our clinical experts and our patient partners. If you could make an introduction too, that would be great. Thank you.
I'm Susan Layton. I'm a 20-year survivor of stage 3C ovarian cancer with recurrence 12 years ago, currently disease-free, and a 5-year survivor of breast cancer. And I do not have a BRCA mutation. Just put that right out there right now. I am the National Program Director for the Ovarian Cancer Research Fund Alliance Survivors Teaching Students Program.
Hello, I'm Betsy Neisner from Massachusetts. I'm a 15-year survivor of stage 3C. I have a BRCA1 gene mutation. I treat at Mass General Hospital. I've had 7 courses of chemo. I'm on olaparib right now, so I guess I have conflict. And I've been on it for 15 months, and I'm doing well. I'm trying to stay at the tail end of the bell curve for longevity. And I've had 4 surgeries, including surgery for a met to my brain from the ovarian and a colostomy. But nevertheless, I persist.
Hello, my name is Andrea Vonner Hendrickson. I'm a medical oncologist that treats women with gynecologic malignancies, and I practice at the Mayo Clinic in Rochester, Minnesota.
Thank you very much. So we have a full day ahead, and thank you for all the guests that have traveled to St. Louis today to be part of this program. We're thrilled to have you, and look forward to presenting all the information and the rich discussion that I'm sure we will have today. So next, I'll introduce our president of ICER, Steve Pearson, to kind of get us started with today with some housekeeping as well as introduce the plan for the day.
Thanks, and good morning, everybody. Welcome. Welcome to St. Louis. For those of you who are traveling, thank you for being here. This is going to be a very interesting and important meeting, and we're very blessed to have the patient representatives and clinical experts here to help us out. It's hard to start without noticing that it happens to be Ovarian Cancer Awareness Month. So we all believe that this is obviously an area in which a lot of innovation is occurring, and that's one of the reasons that we're here today. I also feel compelled to note one of my mentors from my medical student days and residency days passed away from ovarian cancer over 20 years ago. Her name was Margot Fanger. She was a beloved teacher and clinician at the Harvard Community Health Plan. So it's in some ways nice to come back at a time when there are some exciting new potential treatments for ovarian cancer on the table. So we are here today for several reasons. One is this innovation that is promising really outstanding benefits to patients and to their families. And I have a couple of quotes, one from an ovarian cancer survivor who wrote us describing her experience. And she said, 2/3 of women are diagnosed in advanced stage where there is no hope of cure, remissions become increasingly shorter, and then the cancer becomes a chronic disease. Chronic in the case of ovarian cancer means that you live on an increasingly limited menu of chemo and clinical trials along with their host of side effects, praying that each one will hold you for a long time while knowing that the cancer ultimately becomes resistant and you'll need to find something new. We heard from many people about the importance of innovation in this area. One quote from Facing Our Risk of Cancer Empowered or Force said, "The approval of Lynparza marked the first new treatment for ovarian cancer in 6 years. The investment made in this personalized approach to cancer was extraordinary. A decade of research and the participation of thousands of cancer patients enrolling in PARP inhibitor clinical trials to advance science for themselves, but also for their families." So this innovation that's promising important new potential benefits for patients is a key reason we're here today. The other is that we know that often when treatments arrive with new mechanisms of action that shake things up, start to change the paradigm for care, it does often raise questions about appropriate use and sometimes about the pricing and the cost to patients and to the health system. We also know that increasing healthcare costs overall do affect individuals, and they affect state, federal budgets in many different ways. And today, patients can have difficulty accessing drugs through insurance barriers and or high out-of-pocket costs. So we believe that it's important to have a clear process for trying to look at the evidence, for bringing that into a public setting like here today, and to involve all the different stakeholders in having conversations about what we know from the evidence today, where the research needs to lead us, and what we can know and think about value, and how we apply that in a healthcare system to really benefit patients today and in the future. So that's the role of the Midwest CEPAC. And you just heard, they're an independent group that we convene, and they have had the charge of looking at the evidence, of already working with clinical experts and others to try to understand this evidence, and they're here today to wrestle with these questions and to engage with stakeholders in discussion. ICER serves as the kind of academic foundation for the report, and so I need to tell you a little bit about ICER. First, our sources of funding for this year come from multiple sources, but as you see, the vast majority comes from a set of nonprofit foundations, chief among which is the Laura and John Arnold Foundation. So the money that we bring in to do our reports comes from those nonprofit foundations, and then we have about 22% that comes from a mix of sources, a very small sliver left over from government grants and contracts, and money that we bring in to run a policy summit process that's separate from these meetings, that's split about half and half between money from manufacturers and from health plans and other insurers. That money comes in specifically for that program. So the report today was produced over about an 8-month period. And it starts with what we call scoping. That means trying to sort out what the key questions are, where the right comparisons are to be made, and we do that with guidance first from patient groups. We talk to the manufacturers extensively. We also work with clinical experts and other stakeholders at the outset. Then we kind of take that process, and an internal kind of review team at ICER looks at the clinical effectiveness evidence, and we often work with external academic colleagues, in this case from the University of Colorado, to design a cost effectiveness model to try to help inform our judgments about long-term value. This work goes through several different phases of public comment and revision, among which we benefit from clinical expert report reviewers Dr. Gina Fleming, and Dr. Warner Hendrickson, who's here with us today. And before we really get launched in, I want to kind of share how the reports are structured to reflect the way that we are trying to talk about evidence on effectiveness and value. So we start by identifying a goal, which we really do believe all stakeholders in the healthcare system and beyond that it's shared. And that goal is to provide sustainable access to high-value care for all patients. As far as the evidence to support that, we kind of conceptually divide it into evidence that would help you make a judgment about the long-term value for money and the short-term affordability of treatments. Now, within long-term value for money, it's kind of a complex concept because it involves itself different elements. One is a bedrock look at the comparative clinical effectiveness information. Then, as I mentioned, we look at the incremental cost effectiveness long-term. But we also weave in, and there will be specific votes today, on other benefits or disadvantages and contextual considerations that can be very important in making broader judgments about the long-term value for money. So our reports have these in different sections, and as you'll see, the discussion today and the votes are structured to flow in this way. For short-term affordability, ICER prepares a potential budget impact analysis that's meant to inform basically larger decisions around affordability, and it plays a role there. Sometimes we end up talking on the policy roundtable about whether the long-term value and the short-term affordability are going to come into any potential conflict. So that's the conceptual backbone, if you will, for the way that our reports are structured, and to a certain extent the way that we in our heads are thinking about value. We recognize that value can mean different things to different people, but we hope that people can also look at this template and find what they think is most important somewhere up here, and we hope to make sure that that's part of the discussion today. So the agenda after this presentation, we'll start right into the presentation of the evidence from Dr. Lipika Samal, who's an academic colleague at the Brigham and Women's Hospital in Boston. And then we'll have the economic information, the decision model presented by Brett McQueen, who's at the University of Colorado. We'll have a 30-minute session for manufacturer public comment and discussion. Public comments and discussion will follow that, and then we'll have lunch at 12:15. For the public kind of attendees today, lunch is available downstairs. There's a cafeteria downstairs. It's probably the easiest thing. Then we'll reconvene right at 1 o'clock to start on the specific deliberation that leads to the votes on effectiveness and value. Following that, we have a policy roundtable where patient partners, clinical experts, payers, and we always invite manufacturers. We won't have any today, unfortunately. But what we'll do at that point is kind of pick up the discussion around evidence and value and talk about, what are the options for applying it in the health system, applying it to clinical behavior, to clinical guidelines, to insurance coverage, to pricing discussions, all of that. So we try to kind of flesh that out in the policy roundtable. Then we'll have last reflections, if you will, coming around the table through CEPAC and a wrap up, and we'll definitely be done by 4 o'clock. Restrooms are outside and around the corner. They're pretty good signs to help you find them if you need. I think that's all I need to do to tee us up, but I can't leave without thanking again the patient partners and the clinical experts who are joining us today. They're at that table there so that throughout the process of the kind of presentation of the evidence and the discussion by CEPAC, that they're easily available to ask questions. And with that, I think I can invite Dr. Samal to come up.
Hi, everyone. My name is Lipika Samal. I'm a general internist. I practice at Brigham and Women's Hospital as a primary care physician, and I spend most of my time doing research on electronic health records. This is my first time presenting with ICER. It's been a really great experience. I just want to do a very brief evidence review. I don't want to go over the entire report, but highlight some of the main points and talk about some of the areas of confusion. And I'm happy to take questions from the panel during my presentation. I don't have any disclosures. I'd like to recognize the ICER team, Dan Ohlendorf, Jerry Kramer, Patty Sinha, and Aksa Magal. just do a very brief statement about the topic in context. So, I think as we all know, ovarian cancer is the most common cause of gynecologic cancer death. It's the fifth leading cause of cancer death in women overall. And we all know that this is a disease with very common recurrences, and the prognosis is poor after 3 lines of therapy for many patients. We're all here to discuss the PARP inhibitors. This is a group of agents with a new mechanism of action. They are oral agents, and initially they were approved for patients with genetic mutations affecting DNA repair, such as BRCA1 and BRCA2 mutations. And just a note for people that are maybe not as familiar, those mutations were initially discovered in breast cancer, but they also are very important as we think about patients with ovarian cancer. Some of the key terms, going into more detail about that. So first of all, you'll see this G-BRCA-M abbreviation. That stands for germline BRCA mutation, and this is an inherited deleterious mutation in either BRCA1 or BRCA2 tumor suppressor genes. You'll also see S-BRCA-M. This is a somatic BRCA mutation, and it's either deleterious or suspected deleterious in one of those genes that's acquired during a patient's lifetime. And then finally, we'll touch a little bit on what's known as homologous recombination deficiency, or HRD. And this is a group of mutations which affect the cell's ability to repair damaged DNA. All right, so this is a very busy slide, so I'll just orient you to the columns. So the first column, it shows the 3 PARP inhibitors that we reviewed the evidence for. The second column talks about indications, which I will go into in more detail. The third shows the dates of approval, and the last is the wholesale acquisition cost per month. So first of all, the first column, the 3 PARP inhibitors that we'll be discussing today are olaparib, rucaparib, and niraparib. In the second column, indications, you'll see that olaparib has 2 different indications that we'll be discussing. And the first is in patients with a germline BRCA mutated tumor, or not tumor, sorry, germline BRCA mutated disease, who have received 3 or more prior lines of chemotherapy. The second indication for olaparib is maintenance treatment for platinum-sensitive recurrent disease. You'll see in that same row that the dates of approval for the first indication was December of 2014, and the second, very recently, August 17, 2017, and you see the price there. The second agent, rucaparib, we're only looking at patients with germline or somatic BRCA mutated recurrent disease, and those who have received 2 or more prior lines of chemotherapy. So you're already kind of seeing there's a little bit of a difference between the first indication for olaparib and the indication for rucaparib. The date of approval for rucaparib for this indication was December of 2016, and you see the price there. And then finally, niraparib. So niraparib, we're only looking at the maintenance therapy indication, maintenance treatment for platinum-sensitive recurrent disease. And this approval was given in March of 2017. So I just want to again highlight the differences in the types of BRCA mutations, whether germline or somatic, and the number of prior lines of chemotherapy in the first indication for olaparib and rucaparib's indication. Just going to shift a little bit over to some of the insights that we received from patient groups. And once again, we're very thankful that we have patient representatives here. We also had the opportunity to speak to many patients during the course of writing this report. And so just to summarize some of the experiences that we heard about, this is a very difficult diagnosis for patients. People realize there's a low likelihood of cure. The nonspecific nature of symptoms is very tough. Sometimes people have symptoms, they don't know if it's from the disease recurring or if it's from the surgery that they underwent. So that is very tough for people. And then up until recently, people receive many lines of very cytotoxic chemotherapy, which have very substantial side effects. We also learned that having psychosocial support from healthcare providers, family, other caregivers is really, really important. And also that the financial toxicity from cost of their initial treatment and multiple lines of therapy can be pretty substantial for these families. All right, so shifting back now to kind of the real in the weeds. I want to make sure we really are on the same page in terms of the populations of interest. Throughout the day, it'll be really important to identify when you're asking a question or looking at the evidence, whether you're thinking about population 1 or population 2. Population 1, we are referred to in the report as recurrent BRCA mutated disease. These are patients that have deleterious BRCA mutations and have relapsed after multiple lines of therapy, chemotherapy. Population 2 is the maintenance population. These are patients who have platinum-sensitive disease. They've received 2 or more prior platinum-based chemotherapy regimens, and they are in complete or partial response to the most recent regimen. We pick these populations based on current and expected indications. We can go over the definition of platinum-sensitive in more detail if people would like me to, but I'm basically just going to tell you that it means a platinum-free interval of more than 6 months, and that's measured from last infusion of platinum in primary treatment to the documentation of recurrence. All right, so now going into interventions and comparators, and these are going to be presented for each population separately. For population 1, recurrent BRCA-mutated disease, the interventions of interest are olaparib in 4th line or later treatment, and rucaparib in 3rd line or later treatment. And the comparators that are listed here were chosen based on clinical expert suggestions and represent some of the commonly used therapies in this setting, in these populations, but these are not comparators that were used in the clinical trials. I just want to really emphasize that. So I'll come back to that again when I show you some of the data about these comparators. But these were not comparators in the trials themselves. Population 2, maintenance therapy for platinum-sensitive disease. We're interested in looking at data on olaparib and niraparib. We're aware that the Ariel 3 trial was published yesterday, rucaparib, and what we've seen is that the findings for progression-free survival were fairly similar to what we've seen in other trials, but we'll be summarizing that data more fully in the report. We won't be going over that today. So the comparators here are placebo and bevacizumab, and these are what we reviewed for the clinical effectiveness evidence review. The modeling team is going to talk about decisions that they needed to make for their economic models. So you'll see that when Brett comes up. Okay, all right, so moving on to the results. We were able to identify 15 reports and 6 studies. Many of these reports were from the gray literature, which means conference proceedings, publicly available FDA materials, and data submitted by the manufacturers. So in the first population, the recurrent population, we found only single-arm trials. In the maintenance population, we found 3 peer-reviewed studies that included a control arm. Okay. So what's really, I think, for those of you who are familiar with ICER reports, what's really important to emphasize right now, right for the rest of the day, is that we are not, we did not identify any head-to-head studies of PARP inhibitors. We are not trying to make direct or indirect comparisons between these 3 agents. There are major differences in the study populations, very different patient populations in terms of BRCA mutation type, the number of prior chemotherapy lines, and platinum sensitivity. There are also major differences in outcome assessment. The evaluation protocols differed widely across the studies. So for example, there are different intervals between the scheduled measurements of response. There was also differences in terms of whether it was an investigator assessment or a blinded independent central review, referred to as BICR. For example, in some studies, progression-free survival was assessed at 8-week intervals and in others at 12-week intervals. All right, so diving into the results. So first of all, thinking about olaparib and thinking about the first population, recurrent BRCA mutated disease, we found a subgroup analysis of one of the single-arm trials, or one single-arm trial, and the results here, median overall survival of 17 months and a median progression-free survival of 7 months. Underneath those bullets, you see something that says 6 to 9 months with standard relapse therapies for overall survival, and 4 to 6 months with standard relapse therapies for progression-free survival. Once again, these are indirect comparisons, and they're based on historical data that was taken from a pooled analysis of studies in ovarian cancer where patients had unknown BRCA mutation status. Okay, switching gears, olaparib in the maintenance therapy population. So we found 2 randomized controlled trials of olaparib versus placebo. One was a phase 2 study called Study 19, and the other was a phase 3 study called Solo 2. There were key differences between these studies. So one key difference was that the dosing and formulation of the treatment were different in the 2 studies. And another is that the BRCA mutation status was different in the two studies. So, for example, in SOLO 2, the inclusion criteria was that patients really had to have BRCA mutation, whereas in study 19, only about a third of patients had a BRCA mutation, 36%. And in terms of dosing formulation, in study 19, patients received 8 50 milligram capsules twice daily, but in SOLO 2, patients got the new tablet formulation, which was a 300 milligram tablet twice daily. So far, the overall survival analyses are not showing a benefit in study 19, and in SOLO 2, data is still immature, but interim analyses are not showing a difference between olaparib and placebo in that study. Okay. Now, maintenance therapy, we're still on maintenance therapy. Now going more deeply into the progression-free survival results. In study 19, so the median PFS, 8 months versus 5 months for placebo. Looking at some of the subgroups, patients who have BRCA mutations, the progression-free survival was 11 months versus 4 months for placebo. And then patients who did not have BRCA mutations, the progression-free survival was 7 months versus 5.5 months. In SOLO 2, the median progression-free survival was 19 months versus 5.5 months in placebo. And we did not see any significant differences reported in quality of life measures. There are some recent abstracts showing some positive results for secondary measures of quality of life, but so far published data does not show significant differences. Another kind of thing to point out, again, as we're talking about the different trials, SOLO 2 used the investigator-assessed progression-free survival as a primary endpoint. You know, and in, for example, in the key trial of niraparib, that was a secondary analysis, and the BICR analysis was the primary endpoint. All right, so moving on to niraparib in maintenance therapy indication. So we have this one RCT. This did not show an overall survival benefit, but the data is still immature. We once again are looking at the results broken down by BRCA mutation status, and not surprisingly, we see that the germline BRCA mutation patients have a progression-free survival of 21 months versus 6 months for placebo. In the non-germline BRCA mutated group, the numbers were 9 months for niraparib, but 4 months for placebo. And then we were able to see, look at some other indicators of homologous recombination deficiencies, and we know that patients that had HRD and a somatic BRCA mutation showed a progression-free survival of 21 months versus 11 months for placebo. And then the benefit for patients that did not have a BRCA mutation or an identifiable HRD mutation had a benefit of about 3 to 5 months. We didn't see any significant differences in quality of life as well. Okay. All right, so going into rucaparib. So going back again to the first population, recurrent BRCA mutated disease, we have subgroup analyses from 2 single-arm phase 2 trials. We do not have overall survival data. I would also say that this data that we reviewed was conference proceedings only, so these figures are based on pooled data from those conference proceedings. And what we saw was a median progression-free survival of 10 months. And, you know, once again, just giving you a benchmark from historical data, it's about 6 months with standard relapse therapies. But this is not data from these trials. And quality of life data was not reported. Okay, so I'm now switching gears a little bit, so I'm done telling you about the evidence that we reviewed. I'm going to talk a little bit about the harms. So, you know, what we heard from patients and what was reported in the studies, common side effects are nausea, vomiting, anemia, thrombocytopenia, and neutropenia. Across the studies, dose reductions were pretty common, anywhere from 22% to 67% of the time doses were reduced, you know, versus something like 3% with placebo. The most feared complication, there's an FDA warning for myelodysplastic syndrome, or MDS, and acute myeloid leukemia, AML. And this occurred in less than 2% of patients, but was very serious and actually led to death in some cases, so very important to keep in mind. On the other hand, you know, it's important to say that what we've heard from patients is that these agents are better tolerated than alternative therapies for recurrence, and some of those therapies have black box warnings, including for cardiomyopathy, very severe infusion reactions, GI perforation, and hemorrhage. And also another point to bring up is that patients that experience MDS or AML, it's unclear whether that's from the PARP inhibitor or other chemotherapy that they've received, including the alkylating agents and platinum agents. We generally heard from clinicians and patients that most people feel like these side effects are manageable and they can be handled through dose modifications. All right, so if you had a chance to review the report, we had a pretty significant section on controversies and uncertainties. I'm just going to highlight a few of them that I think are really important and we can discuss more. So first of all, very important, we're not seeing overall survival data that demonstrates a benefit over historical treatment options. That is really the favored endpoint, but it's very difficult to demonstrate overall survival benefit. And, patients have received many different recurrence therapies. It's hard to know what to attribute overall survival benefit to. So the second bullet point gets the next issue or thing to think about, which is that progression-free survival is really favored as a primary endpoint in these trials. There's been a lot of discussion about whether or not this is the appropriate endpoint for evaluating clinical benefit in a maintenance setting. It depends on the patient. Some people really feel like extending that time between the cytotoxic chemotherapy is very valuable. Others might feel like, if there's not an overall survival benefit or quality of life benefit, they may not want to be on a medication in the maintenance setting. They would just not have to go in to the doctor and not have to have blood draws and things, and they'd be on a drug holiday during that period of time. So it's very individual to the patient. The third bullet, so it's very important to recognize there's no comparative data in population 1, the recurrent BRCA mutated ovarian cancer population. These are single-arm trials. And so, gains in PFS, OS, quality of life, we don't really know how that would compare if there was an active comparator in those trials. Okay, this next slide is related to the new voting section for the panel, other benefits and contextual considerations. So I'm raising these considerations to kind of get people thinking about some of these a little bit harder to things that we don't necessarily have data for, but we want to consider and think about and have a discussion about. So, first of all, these drugs really have a novel mechanism of action, and they look like they might be improving progression-free survival over standard relapse therapies. This is very exciting in a field that's had very little progress for many decades. Second of all, the low-grade adverse effects are much less concerning for patients than what they get with cytotoxic chemotherapy. We don't have any data on, for example, productivity benefit, but you can imagine that might be the case as well. Third, these are oral agents, so the simplicity of that is huge for patients. Less travel to infusion centers, maybe a reduction in caregiver and family burden. They do still have, in the maintenance setting, they do still have to have blood draws, and they do still have to have some contact with their clinician. So there are still some things that go along with that in the maintenance setting. All right, so we also received many public comments which are available online. I'm just going to highlight a couple of them. So, one is that the most appropriate comparison would be a head-to-head comparison between PARP inhibitors. And, this is really what we would have liked to do, but for some of the reasons I've mentioned, the populations are just really, really different. The inclusion criteria is really different in the published studies. And also outcome assessment is very different, so we were not able to do that. Another is concern that we're minimizing the benefits of progression-free survival of patients, and I kind of touched on that, but you just want to make it clear that we understand this is really an important patient-centered outcome. We also understand that some patients don't want additional toxicity during a time when they would normally not be on a medication, so each individual patient, their clinician, family need to think about their genetic markers or makeup, their history of treatment, their current clinical status, and side effects that they might experience. So just to summarize, so population 1, recurrent BRCA mutated disease, we have only single-arm data. Second point, the progression-free survival benefit over historical comparators and placebo is what I presented there. So for population 1, it's historical comparators. For population 2, placebo or other comparators. It does appear that in the maintenance therapy population 2, the greatest benefits are in the germline BRCA mutation situations, or people who have an identifiable HRD, homologous repair deficiency. Our data on overall survival is extremely limited. And finally, we did get the sense that the toxicity profile is favorable compared to standard chemotherapy regimens. And so just to finish, this is the summary of the evidence ratings. So, first of all, for olaparib, in the first population, olaparib in the first population, recurrent BRCA mutated disease, we gave a rating of promising but inconclusive. And the reason for that is that the trials are single arm, but the promising piece of that is that we're giving some benefit of the doubt that these treatments are less toxic than the standard chemotherapy regimens. We can't definitively know that without an active comparator, but that's why we have the promising but inconclusive rating. Rucaparib, also promising but inconclusive, similar rationale. And then niraparib, there's an ongoing study, but right now insufficient evidence for niraparib in that population. The next set of rows there, maintenance therapy in platinum-sensitive disease, this is population 2. So for olaparib, the C+ rating means that we think that this is at least as good and likely better than placebo. The plus indicates that we have a high level of certainty that it's at least as good as placebo. And for niraparib, we gave the same rating. And then for rucaparib, once again, right now, at the time of writing, insufficient evidence for rucaparib. And with that, I will turn it over. Thank you very much. Oh yeah, and are there any questions from the panel?
I'll be attentive to this signal, which says you'd like to make a comment, and we'll make sure that we call on you by the speakers. So it's always, and feel free to sort of interrupt a bit so we can get a bit of a conversation going. But are there any questions as we, based on the data that's been presented so far? Any thoughts, reactions? Okay, all right.
Thank you.
Yeah, great job.
Excellent. You all hear me? Okay. Bit of a big voice, so. My name is Brett McQueen. I'm an assistant professor at the University of Colorado, and along with my collaborators from Colorado listed here, we were tasked with doing the long-term cost-effectiveness modeling on this. I'd also like to acknowledge ICER, not only for their financial support, but just the great team that they have. They're really a great group of collaborators, and I've really enjoyed working with them on this project. So thanks, everyone. Really appreciate it. We have no other conflicts in terms of funding related to ovarian cancer. So our objective was to model the costs and outcomes for the 3 PARP inhibitors in question today: olaparib, rucaparib, and niraparib, and the treatment of adult women with ovarian cancer. So I'm going to go over a few of the methods in brief. As Dr. Samal discussed, we're not looking across PARP inhibitors. We're looking at them versus relevant comparators. So in the treatment of recurrent BRCA mutated disease, we're looking at olaparib versus PLD plus C in 4th line or later use, rucaparib in 3rd line or later use versus PLD plus C. And then in the maintenance treatment for platinum-sensitive disease, we're looking at olaparib versus placebo in surveillance only. And then niraparib we split by germline BRCA and non-germline BRCA status versus placebo. Brief topics on methods here. We used what we call a semi-Markov model, and really just to make it simplistic, it's ideal if you want to model additional lines of chemotherapy. So it's a nice way to be a little bit more flexible than, say, a partition survival approach. The time horizon of 15 years is reflective of the shortened lifespan for these women as compared to other women of the same age without ovarian cancer. Our primary outcome is cost per quality adjusted life year gained, and then our secondary outcome is cost per life year gained. This here is a model schematic. So you'll see on the left-hand side those populations that I just discussed. And in the middle, these are the discrete subpopulations, the comparators that we're making. So again, we're not comparing across PARP inhibitors. We're comparing them to their other relevant comparators. And on the far right-hand side, you'll see here, we have a general model schematic that's informed by the evidence. For example, we have progression-free survival, which we can split into on or off treatment, which is reflective of our semi-Markov model. It allows us to build in that additional flexibility. Progression and then death are the other health states included. There are a number of assumptions that we made. However, I think there's really two to point out. Overall survival evidence was immature for rucaparib and niraparib at the time of this analysis. So we had to apply some olaparib evidence on overall survival to the similarly treated or indicated populations to estimate life years gained and ultimately quality adjusted life years gained. The second assumption also has to do with overall survival, but really the link between progression-free and overall survival. So what is that relationship? And so while we use the most recently available progression-free survival evidence, say from SOLO2 for olaparib, we're still relying on study 19's relationship between progression-free and overall survival. And if you have any questions about that, I can expand. But for example, in the BRCA mutated subpopulation, there was an observed approximate 1 month gain in overall survival for every 2 months gain in progression-free survival. This table includes the full dose drug cost. You see the wholesale acquisition per unit and month, and then the net price, which is an assumed 10% off of our wholesale acquisition cost. Now, this was in part informed by manufacturer input. So while it's an assumption, there was some information from manufacturers. Now, this again is the full dose. We're not modeling the full dose over the entire course of the model. We model it similar to the observed trial evidence. So we start patients on the maximum dose or the full dose, and then there's a de-escalation process in the model that we forecast. And then they end up in sort of an average dose over time for the remainder of the model for those that are progression-free and on treatment, similar to what you'd see in the actual trial. These are the grade 3 or 4 adverse events. Now, we only include these adverse events in the model if they're experienced by more than 5% of the population. And we include it in the model in two different ways. First, there's a disutility related to these that lasts approximately about 3 months in the model, which is 3 cycles. And then we also include an adverse event cost, which is only 1 cycle or a one-time event cost. And we can vary that cost all the way from very low values to high values to represent different intensities of care, for example, outpatient versus inpatient visits. So let's jump into the results. The first you'll see here for the base case results for olaparib. On the left-hand side, you'll see three different cost columns. The first is the intervention cost. Now, this is representative of the cost of the PARP inhibitor in question, in this case olaparib, along with any subsequent chemotherapy costs. And then the non-intervention costs include supportive care, so office visits, CT scans, and then for individual PARP inhibitors, there is a blood test specifically for olaparib as well, and then any adverse event costs, which I just mentioned, and then end-of-life costs we also include as well. You'll notice a couple of things as well. So we have, so on the far right-hand side, before I move on, we have the effectiveness estimates, which are life years gained and quality adjusted life years gained. You'll notice two different things. The life years gained here is a little bit smaller in the recurrent BRCA mutated population versus the maintenance therapy. This represents the fact that the recurrent BRCA mutated population is sicker. They're on a later line of therapy, so survival is shorter in this population. You'll also notice that the treatment costs for olaparib and the maintenance therapy are significantly higher than the recurrent BRCA mutated population, and this is reflective of a longer time spent in progression-free on treatment state. So that's why that cost is slightly higher. So, for example, in the recurrent, for the actual results, in the recurrent BRCA mutated population, we see approximately 80,000 per life year gained for olaparib versus PLD plus C in 4th line or later use. and approximately 145,000 per quality adjusted life year gained in the recurrent BRCA mutated population versus PLD plus C. So I want you to interpret this result with a little bit of caution for a couple of reasons. First, this is not direct head-to-head evidence versus PLD plus C. This is historical data because the trial was a one-arm trial. Second, PLD plus C evidence did not break down by BRCA status as well as line of therapy. So, and there is recent evidence and past evidence that suggests BRCA mutated patients are living slightly longer. So if we think about this, this could, if we did break it out by BRCA, potentially sort of increase our ICER by reducing our effectiveness estimates in the denominator. So I just kind of want you to think about that.
So just to, can I ask?
Sure.
The difference between the 2.11 and the 0.91, or I guess about 1.2, represents you're estimating a 1.2 increase in life
in survival. Yeah. Yep.
Okay, and then you're also saying that the 0.91 might be biased a little low based on the BRCA.
All I'm saying is we don't have the evidence that splits out BRCA and non-BRCA by line of therapy. So it's a challenge in this area. So that's why I just wanted to caution you on interpreting the results.
Okay.
Yeah. And we could talk more about it in Q&A. And then for the maintenance therapy for platinum-sensitive disease, we're seeing approximately 288,000 per life year gained and 324,000 per quality adjusted life year gained in the maintenance population. We also ran some threshold results, which means essentially what would the price have to be reduced to achieve the 50, 100, and 150,000 per quality adjusted life year threshold. We found approximately 8 to 60% in the recurrent BRCA mutated population. Please note that the 10% we assumed actually exceeds that 8%. And that tracks with the cost effectiveness estimate of approximately 145,000 per quality adjusted life year. In the maintenance for platinum-sensitive disease, we see approximately 60 to 90% discounts to achieve those thresholds. So now on to niraparib. Niraparib was split by G-BRCA status and non-G-BRCA status from the trial. You'll notice again, we have difference in effectiveness and difference in cost. The treatment costs for germline BRCA are slightly higher than the non-germline BRCA because of a longer progression-free on-treatment disease state. So they're just spending longer in that state and incurring more costs. We see approximately 245,000 per life year gain and 290,000 per quality adjusted life year gain in the germline BRCA population versus placebo. We weren't able to estimate a difference in life years gained because the evidence, the only evidence available in the non-germline BRCA suggested no difference in overall survival. But we were able to calculate a cost per quality adjusted life year gain, which was approximately 1.9 million per quality adjusted life year. We also ran threshold results just for the germline BRCA. It was the only available analysis for this, and we found about approximately 60 to 90% reductions from wholesale acquisition costs to achieve that $50, $100, and $150,000 per quality adjusted life year gain thresholds.
I have a question.
Sure.
How many people were enrolled in this trial?
In the niraparib trial?
Yes.
I'd have to turn that over to our clinical expert. So.
Great, thank you. And was this, did they do subgroup analysis on the populations of interest?
They did split it. I know they did split it by germline BRCA, non-germline BRCA, and I don't recall if there was a third group, but I believe those two were the focus of the modeling analysis, and I know they split those two out.
Okay, so pooled analysis for main results and then subgroup analysis for these two, correct?
True. So the main analysis, it's a good question. The main analysis splits the germline and non-germline BRCA. They did combine germline and non-germline, and we do that in a scenario analysis that I will actually be talking about in a few slides.
Great.
So it was those three main groups that we modeled.
Great, thank
And
you.
I can just jump in for a second here. I've got the numbers. So in the niraparib trial, germline BRCA N was 138. Non-germline BRCA was 234. And then the placebo group, germline BRCA was 65, and non-germline BRCA 116.
Great,
2 to 1.
Thank you.
Thanks, Dr. Small. So in terms of the base case results for rucaparib, Again, we see a slightly higher cost than possibly in later lines of therapy. This is because we're looking at third line or later use. So it's a little bit moved up in terms of the line of therapy. For cost effectiveness estimates, about approximately $217,000 per life year gain and $295,000 per quality adjusted life year gain. We did, again, run a threshold analysis and found approximately for rucaparib versus PLD plus C in third line or later use of about 50 to 75% discounts from wholesale acquisition cost to meet the 50 through 150,000 per quality adjusted life year gain thresholds. So what you're seeing here is a tornado diagram, and this represents individual one-way sensitivity analyses. So we vary individual inputs by plus or minus certain values, and then we see the impact on our results. So these are just individual one-way sensitivity analyses while holding everything else in the model constant. You'll see utilities, costs of the treatments, and some adverse events as main drivers of the model. One thing to note with the lack of comparative data, one, and as well as the model structure, we weren't able to include any sort of analyses around progression-free survival or overall survival. It was very difficult to do any one-way sensitivity or probabilistic sensitivity analyses around those parameters. We also did run a probabilistic sensitivity analysis, which in a sense gives us an idea of the percent of our simulations that are cost effective at the different thresholds of 50, 100, and 150. All were below 2% with the possible exception of olaparib versus PLD plus C in fourth line or later use, at approximately 50% cost effective at 150,000 per quality, and that tracks with the base case results as well. So the scenario analysis, we did combine the germline and non-germline BRCA, particularly in the olaparib and the niraparib subgroups. And we did make those comparisons, which resulted in slightly higher cost effectiveness estimates. Again, if you recall, the germline BRCA had longer PFS on treatment versus the non, so it sort of emerged between those two. We did do a variety of sensitivity analyses around different progression-free survival estimates, such as the Bicker curve that Dr. Samal mentioned. And we saw slightly lower cost effectiveness estimates, but of similar magnitude. And one area that's very important, I think, methodologically, is to do a different type of what we call a structural sensitivity analysis. So we actually did what we call a partition survival method and found really similar results, about within 10% of our base case. And you can see that result in the report. So there are significant limitations to note here. I did talk a little bit about this in the key assumptions, but we were really limited in terms of both overall survival, so immature overall survival data, as well as that relationship between progression-free and overall survival. So we had to make some assumptions, which I did note. I've also noted that the PLD plus C evidence is derived from a mix of BRCA and non-BRCA mutated populations. And then any infusion fees or provider markups for PLD plus C were not included. However, we did vary the price of that treatment, and we're relatively insensitive to changes in those costs. And then as well, I think I mentioned already that we really had difficulty generating any uncertainty around our transition probabilities, which would affect that progression-free and overall survival variation. So to note that's pretty important. So in terms of conclusions, the PARP inhibitors are likely to provide gains in quality adjusted and overall survival over the alternative therapies, but they're not currently priced in alignment with these benefits, with one possible exception, which is the olaparib in recurrent BRCA mutated ovarian cancer. Public comments, we saw a lot on enhanced transparency for different model calculations. We provided a full detailed table that you can use to replicate the model in terms of our parameters, as well as how we calculated that dose escalation analysis. And then we also got a comment on equivalency between progression-free survival and overall survival, so setting PFS and overall survival as a one-to-one relationship. However, that evidence really wasn't there in the literature, and that's not what we found. And so we did do some things to calibrate the model, and I believe I gave an example of the 2-to-1 relationship of 2 months of progression-free survival results in about 1 month gain in overall survival. So So I can take any comments on the analysis, modeling analysis now.
Anybody have any questions or comments to get us started? Yeah, Matthew.
A question about your choice of the regimen for control PLD plus C. We have several options in the platinum-sensitive space. Why that regimen, and did you consider some of the other regimens, especially the one that has overall survival benefit of carboplatin paclitaxel plus bevacizumab?
Yeah.
Is that the reason that was considered?
Yeah, so we did, so there's a couple of issues there. So we actually calculated, it's not in the footnote, but we calculated PLD plus C based off of two parameters, weight, and then there was one other lab value that we used as well that's listed in the report, and we used previous evidence to calculate that. It was sort of an average, for an average patient for the dose.
As far as the choice of the regimen, we had some of the regimens we could use
Sure.
in that space.
Yeah. We did look at Beva, we did discuss bevacizumab as a comparator. However, the evidence within this population was not there in terms of the literature. And that's
E218 would be something that probably should be considered, especially with the overall survival benefit.
Yeah.
Ends up being a comparator that probably should be considered in this platinum-sensitive population.
Let me just chime in. So what we wanted to make sure we did, because again, these were single-arm studies, so we didn't have an actual comparator to work with, was to try not to overly complicate the model by comparing to multiple regimens. So we did solicit a fair amount of clinical expert input in the beginning of the process. PLD plus C was something that was mentioned to us on a relatively frequent basis, and we did have information available at a similar line of treatment to be able to make some comparison. And Brett noted the limitation with that because of the mixed BRCA and non-BRCA population, but we had some information to directly compare. I think the consideration of bevacizumab was more around the maintenance comparison. But
now we have a regimen that, of course, not yet FDA approved, does have a statistically significant benefit of overall survival, which is the bar that we've been looking at. And does that now trump the regimen choice chosen?
And Dan, what would that, Brett, what would that do? Yeah, what does that do to the cost-effectiveness ratio? I mean, how does it seems like we've taken a bit more of a conservative approach, if I have interpreted this correctly.
Yeah, that's true. And if we did have more of a head-to-head comparison with the bevacizumab, it is possible that we would see a different cost-effectiveness ratio in terms of maybe it would go up if the survival was longer and the comparison. So that denominator, remember, if that survival shrunk, if that incremental shrunk, then we'd see the incremental cost-effectiveness ratio go up.
although it's hard to say.
It's hard to,
Bevacizumab is a premium priced product as well.
Exactly.
So, whereas at least the carboplatin component of PLD is generic.
It comes in at a different price point.
Yes.
Much different,
So I was going to ask either, well, I'm glad you're putting up Betsy or Susan, can you, or you can make whatever comment you'd like, but I wanted to get your thoughts on progression-free survival and what that means from a patient perspective, especially as we talk about this, how this gets defined and what this means in these models.
Yeah, I think that's primary. But first about bevacizumab, I wondered, I didn't see any statistics on the number of women who cannot take bevacizumab because of colon involvement. I know that there's a certain percentage, so it can't be just looking at some kind of combination with bevacizumab against PARP inhibitors. And also, you'd have to include the costs of treating adverse events from bevacizumab, which can be very expensive.
Yes.
As far as the question of whether increased PFS is a reasonable outcome, where the alternative is death, increased PFS is enormous significance. Otherwise, what you're saying is it's kind of a battlefield triage. The people who aren't going to make it, you don't waste time on. You just work with people who you can increase the overall survival. From the point of view of women with ovarian cancer, when I went to the gynec surgeon the first time, I actually had my first surgery at Dana-Farber, Brigham and Women's, before I switched to Mass General. The doctor was fabulous. He spent over 2 hours talking to me about what to expect. When I left his office, I couldn't remember a word he said, which is very common for the first appointment. But the question I asked the family I was, attending the meeting with was, what do I tell the kids? That's the perspective, that's the difference between the perspective of the doctor, whose role has to be to explain the medicine, versus the state of mind of the patient. And what we want from our doctors is that they're on our team, we're not on theirs. So we want them to be able to say, we have a plan, and if plan A doesn't work, we've got a plan B, a plan C. So to know that olaparib or one of these PARP inhibitors is out there in the future, may even be moved closer to the first recurrence, it gives you hope. And we're talking about quantifying hope, which is very difficult to do. It allows you to think differently about what you're going to do while you wait for the shoe to drop. Are you going to continue work? Are you going to be productive? Are you going to generate taxes for the economy? Or are you going to go on, SSDI and take money from the economy? It could change your mind. This simple PARP inhibitor could change your mind. It also allows you, if necessary, to make plans for end of life, dealing with the family, and that is absolutely crucial. When there was some mention here, I've probably heard it before, but I blanked it out, calling this salvage therapy. So I have this picture of a crusty, rusty old tug, probably built in the 1930s and should be mothballed. And I'm the Edmund Fitzgerald at the bottom of the water, and there's no reason to salvage anything for me because there'll be nothing left when I die. So I would argue that if the goal is sustainable access to high-value care for all patients, increased PFS is a high-value goal.
Yeah, if I may respond to that, in the model, the progression-free survival actually has a higher utility value than the progression. So it is valued in the model. And that's why the quality-adjusted life year gained estimate is different than the life year gained estimate. So it is actually valued more in the model. So.
Well, model aside, in the minds of everyone who's here and who's going to vote, I just want them to understand the perspective from the patient.
Thank you, Betsy. Susan?
Yeah, to answer your question a little more directly, if you attend a group of ovarian cancer survivors, I just recently attended the Ovarian Cancer Research Fund Alliance Conference, close to 300 survivors in that room. You didn't hear a lot of talk about overall survival, except for dinosaurs like me who've been around a long time. You hear things like, I want to see my children live. I want to see my child graduate. I want to see a grandbaby. You hear segments. You don't hear about, I want to make it to be 85 years old, because they know the reality of this disease. So that's where their value lies. That's why progression-free survival is such an important endpoint for them.
Thank you. Thank you very much for your perspective. One of the things that I've wondered about this exercise is that we are modeling costs to the system, but we are
Rena.
I'm sorry.
So just thank you.
Sorry, excuse me.
Pull it closer.
We're modeling costs to the system, but the model is not sensitive to cost to whom. And because the comparator here is bevacizumab, which is an IV therapy, the insurance structure associated with out-of-pocket costs is very different for those drugs relative to the oral therapies. Could you talk a little bit about financial toxicity related to these two regimens, please?
Yeah, financial toxicity is number one on the minds of a lot of our patients. Our organization has gotten extremely involved in legislative action toward financial toxicity, such things as oral chemotherapy parity bills that are out there. I happen to come from a state that has no such legislation and never will have. I'm from Alabama. It's not moving off the dime anytime soon to make equity for these patients. So the cost to the patient can be extremely high. And we are doing everything we can as an organization to try to do some legislative action to prevent, to help the patient. But it has to be a concern, certainly for the patient. Insurance companies, I don't want to say anything that negative because they do offer a lot of benefit to our patients, but I will tell you it is a very difficult challenge to get some of these oral agents covered.
Susan, in your experience, trying to pull this back to the financial model, so to speak, and the calculations that the team has done, are the price estimates that are built into the parameters of the drug cost, I think it's up on the screen right now, are these in the ballpark of what these would not be the out-of-pocket expenses, these would be borne by the insurance companies, but is this sort of in the ballpark of what patients sort of identify as the cost?
It's close.
Okay.
I will say that the out-of-pocket expenses are very high for patients. They are. And they go into that knowing that, and they have to look for assistance elsewhere. They really do.
That's great. Thank you. Don, did you have a comment?
Well, I guess this could be discussed in the context of the policy roundtable, but two disclosures I didn't make. One is my mother died of ovarian cancer and was very probably BRCA positive because her sisters died at an early age, and now my two cousins have, one died and the other has the BRCA. So I'm sensitive to this. The other is I do a lot of work in the palliative care space, and Betsy and Susan both, I think one thing that we don't take into account is what you described, or what I would call advanced care planning, not end-of-life planning, right? How do I want to live my life? I forget the guy's name, the last lecture guy, who said, this is not about how I want to die, it's about how I want to live, right? And so whether that impacts the economics of this favorably or unfavorably, I don't know. It may be that it increases the need for more intensive therapy outside of the healthcare system. But the light went on that I think this is a very, admittedly, to economists, somewhat of an intangible thing, but to me, it's the essence of progression-free survival. And I wonder if that resonates with you. And you know what I mean by advanced care planning, right?
Yes.
Not end-of-life care. That's part of advanced care planning. But would you agree that this is an important consideration?
Absolutely. I want to make another really tiny point. The report says that the PARP inhibitors require regular monitoring for blood toxins, adding to their cost and diminishing some of the convenience. But people who've been put on PARP inhibitors almost all have portacaths. They have to go see the doctor every 6 weeks.
Anyway.
To have it flushed. And they do the CA-125 test at the same time and check blood levels. So
that's an interesting point. Like you would say there's no reduction in utility.
Right.
Because you're going anyway.
Right.
That's it, right. Mm-hmm. That's a good point. I was actually going to ask one question, if you don't mind, on the tornado diagram, if you could pop that one up.
Of course.
Yep. I didn't quite understand, and maybe others in the room didn't either. The widest bar at the top, can you describe a little bit about what you mean by utility progressed disease?
Yes. So that is the health state of after you've passed from progression-free on or off treatment, and you've passed into the progressed disease state. So that could either be you're on a subsequent treatment or your investigator assessed progressed. And we vary that utility from a lower bound up all the way up to some upper bound, of which we define a distribution around that. And then we hold everything else in the model constant and see what the result is. And that result can vary all the way below 120,000 per quality adjusted life year in this case, all the way up to close to 200,000 per quality adjusted life year.
So for the lay folks in the room, that's the change in utility going from progression-free to now under another line of treatment.
Yeah, while holding everything else constant. So
the worsening of
the worsening.
Right.
How much it is.
Right. So
or the benefit.
Yes.
Of it. We're going all the way from worsening all the way to benefit to see the variation.
Have we now confused everybody as much as we did?
Sorry, yeah.
Let me try, because I think the core of your question is what makes it less cost-effective and what makes it more cost-effective? Now you answer.
Yes.
Answer.
Yeah.
So what would make it much less cost-effective in terms of that assumption about the quality of life?
If the
when
utility of progressed disease was much more severe than we are seeing at the mean value. And we vary that by, say, we get evidence from a clinical trial, from the elaborate clinical trial. We could say, this is the distribution of that evidence, and if we vary it, it becomes very, very extreme, and one person, for example, or a group of people actually observes a much lower quality of life, that ICER gets pushed way up versus the comparator, which is held constant, PLD plus C. So I hope that helps.
Yeah, I'm trying to connect it to Betsy and Susan's comments about the extreme benefit of being in a progressive-free state, sort of, I think. And I shouldn't say extreme, may not be the right word, but that it is of incredible value.
It's of incredible value because it gives a woman a chance to live.
Yeah.
That's why it's an incredible value. And to Dr. Casey, to your point, the best case scenario for a woman with recurrent ovarian cancer is to be able to sit down with her physician and say, this is what I want to do in the time I have, whether that time be a year, 6 months, whatever. And if this particular agent is going to give me that and the side effects are not that bad, then yes, I want to go on it. I don't care what the costs are. You know, I'm sorry, I don't. Let my insurance company figure that out. That's the way it's going to be. I want some opportunity to live my life the way I want to live it. So.
And hopefully the physician won't say, I can't remember what she said.
I got lucky on mine because I went through a 5.5-year period of wait and watch, and that was my choice. I knew I had a recurrence, but I just said, I don't care. I'm not doing a treatment. And luckily, I had a physician who understood why and agreed. So, yeah, there are some good ones out there.
Steve has a comment.
I want to ask a question of the clinical experts, and I know we need to move on pretty quickly. So I think from a clinician's perspective, if you have a treatment that has equivalent effectiveness and lower side effects, it's a no-brainer. If we're focused on the progression-free survival as a clinical benefit, and we've heard, the testimony from the patients of why it's felt that way. Clinical experts in oncology, there are many cases, at least some, where the progression-free survival doesn't extend overall survival. So you live a year. Progression-free survival might get you a few more months before you recur, but then it ends up, for whatever reason, that the tumors may be more aggressive once it recurs or whatever, but you live a year. So the American College of Oncology, or ASCO, had set out some guidelines considering, what's a clinically meaningful improvement in progression-free survival. And it's generally around 4 to 5 months. This is, again, is hotly debated even within oncology. But from our clinical expert perspective here today, the panel is going to be considering votes, some of which where the only clinical outcome benefit is progression-free survival, and the differences can range from as small as 1.5 to 2 months. So from a clinical expert perspective, how would you relate that in the kind of broader sphere of what's a clinical benefit for these patients?
Matthew,
sure,
or
Matt and Karen.
I'd like to, one comment that, we're talking about medians, and we're not talking about patients, and that when we think about, I think what you're getting at is median survival differences are relevant. But we often have a pretty good indicator of how the patient's doing when we're seeing them. We're monitoring their CM25 often. It's a pretty good indicator of how this patient's going to do on the drug. The exciting thing about PARP inhibitors are that those patients that respond have a long duration of response. And that's the really exciting thing for our patients, that once we identify that patient that is benefiting, they can be on it, duration of response for most of these is in the 9-10 months range. So if you find that patient, they'll respond for quite some time. So it's not that everybody's getting 6 months of therapy. You have a group of patients that's getting 1 to 2 months and clearly progressing. And this is when I'm talking about measurable disease patients getting the drug, not the maintenance phase, because all this goes away when we start talking about maintenance. If you have a patient that has disease on a scan, has symptomatic disease, has a marker, we can quickly identify who's benefiting from this drug and who's not. So it pulls us a little away from this median survival concept. And we're really trying to find these patients now that are benefiting 3, 4, 5 years from this class of drugs. And that's, as an oncologist, that's what I'm very excited about. We have this long duration of response. So trying to get at, you know, when we look at the data on these trials, progression-free survival is when you see a spot popping up on a CAT scan. It may completely be asymptomatic. As one of our survivors said, she chose not to be treated for a long time. She was without symptoms, without recurrence. So it gets very hard to interpret spot on a CAT scan versus symptomatic, you know, a pro for a patient. And I'm talking a little bit in circles here, but it's tricky when you're purely looking at PFS. There's so much more involved.
I have a follow-up question.
I was going to ask, oh, sorry.
I agree.
Okay.
Thank you. So are clinicians getting better at identifying patients that may have more durable response and or may be the ones who actually respond upon first treatment?
Getting better at identifying patients that would benefit from PARP inhibitors, I think.
That's right.
I mean, I think that our clinical experience started with germline BRCA only with olaparib. So we got that signal in that small group of patients. Still, there's only, I think it was 2,000 unique providers of PARP inhibitors in the first 3 years of experience with olaparib clinically. And so it still wasn't widespread because many of us don't see very many patients with ovarian cancers unless you're, you know, at a large center. So what happens in the general community, now that you have approval irrespective of status, you see a lot different use patterns. So it's hard for me to comment directly on your question. I mean, the early adopters, early users, because of clinical trial experience, we all know that, yeah, the GBRCA patients, they do best. And they're most likely to get that long-term survival. But if you look at that 5-year survivors publication that came out for olaparib, I think out of those people that had 5 years on therapy, there were more BRCA wild type than GBRCA. So once you find a patient that benefits, it's not so much what their status is, or not always what their status is.
Thank you.
That's great. Thank you very much. Yeah, Betsy, would you like to close us out on this section?
Yeah, this PFS of a few months. Before I had ovarian cancer, before I became knowledgeable, I'd look at those data and say, what's a few months? Expensive for a few months. But we're born with the expectations of our parents, then our own expectations about what we're going to do far into the future. When you have advanced ovarian cancer, the expectations are much shorter. So it's not a question of, I want to be here when my grandchildren graduate college, grandchildren who haven't been born. It's next month, I have a family reunion in Maine, and I really want to be there. Or my daughter's pregnant, I just want to see the baby before I die. So if you were to look at the anecdotal evidence, and I've been in a support group for 15 years, first group died, second group died, and I hang on. I've been to ovarian cancer survivor retreats for years. I've done the DOD ovarian cancer panels. I ran a community cancer support center for 8.5 years. The anecdotal information that you might not hear is people who are saying, I have this short-term goal and I just want to make it there.
Right. Thank you very much. Brett, thank you very much for the presentation. We're going to move, and I'll let Steve, I think, am I introducing this? We're going to move into the next section, which is manufacturer comments and discussion. And so we have two manufacturers that will be presenting comments at this time. We're going to bring them up to, are we bringing them up front? Or yeah, so they're going to come on up to the front panel to make their comments. We'll start with Joseph Bricina from AstraZeneca, Medical Director for Ovarian Cancer. Each commenter will have about 5 minutes, and we'll try to do our very best to keep you on time. And then just ask each of you to introduce yourselves as you come up. Oh, and we'll do
No, yeah. Oh, thank you, yes. Dr. Bala. For sitting is fine.
So good morning. I would like to thank ICER and Midwest CEPAC for providing me the opportunity to speak on behalf of AstraZeneca today and submit input and feedback during the review process. My name is Josefa Briseno, and I'm a physician trained in surgical oncology and experienced in treating ovarian cancer patients in clinical research and within the pharmaceutical industry. I hold the position of Medical Director, U.S. Medical Affairs for Ovarian Cancer at AstraZeneca. AstraZeneca supports the focus on patients and patient-centric value assessments. These assessments need to be carefully constructed to ensure they do not limit appropriate therapeutic options for patients. Based on this, the AstraZeneca team wants to better understand how ICER evaluates both products from both a clinical and economic perspective. Given that we have already communicated our point of view of how clinical improvements are modeled and valued during the public comment period, today I would like to focus on the patient. The measure of value is complex and subjective, depending on who the stakeholder is and how they are impacted. Much of the debate has focused on price and budget impact of therapies. However, I urge the committee here today to not lose sight of the meaning of these new therapies and treatment options for individual women affected by ovarian cancer. It is important to ensure that these patients continue to have access to novel FDA-approved therapies that can provide a significant clinical benefit. As a physician, I have seen firsthand patients who are not able to access therapies already proven to show benefit in their disease. Ovarian cancer is one of the deadliest forms of cancer. Patients have advanced disease and poor prognosis at the time of diagnosis. And providing therapeutic options for ovarian cancer patients is very important. From a clinical perspective, just 2 years ago, women diagnosed with ovarian cancer had very limited treatment options, including only chemotherapy or clinical trials. Advances in the scientific understanding of disease mechanisms in ovarian cancer has led to more individualized and disease-targeted approaches. PARP inhibitors as a class represent a major innovation in ovarian cancer. Olaparib was the first PARP inhibitor approved in 2014 for treating women with germline BRCA-mutated ovarian cancer who have been treated with 3 or more lines of chemotherapy. Last month, olaparib received FDA approval as a maintenance therapy with women with recurrent epithelial ovarian, fallopian tube, or primary peritoneal cancer who have experienced complete or partial response to platinum-based chemotherapies. These new indications provide treatment for these women in an earlier disease setting, providing an additional treatment option. This recent approval was based on evidence from phase 2 and 3 studies. The results from SOLO-2, our phase 3 trial, demonstrated an improvement in progression-free survival of 13.6 months when comparing patients treated with olaparib versus placebo. Serious side effects or adverse events included myelodysplastic syndrome and acute myeloid leukemia in less than 1.5% of the patients, with a majority had a fatal outcome, and also pneumonitis in less than 1% of patients. The majority of these cases were fatal also. The most common side effects we saw in our trial were included but not limited to anemia, fatigue, nausea, and vomiting. Olaparib has more than 2.5 years of experience and safety surveillance in the United States. Although today's meeting is focused on ovarian cancer and value of PARP inhibitor therapies, any recommendations today must be considered in the context of how they influence public sentiment, payer reimbursement, and patient access. At AstraZeneca, we appreciate and understand that we are called to continually demonstrate the value of our products, and that is why we are here today. We want to better understand how ICER evaluates products, and know the meaningfulness of the current evaluation will likely be limited by emerging new data. In conclusion, I ask each member of today's voting panel to consider all the implications of their votes. These implications could include and impact patient access to FDA-approved drugs and patient treatment options. Thank you.
Thank you very much. Do we have any comments or questions from the ICER team?
I would actually echo the thanks for the comments. We appreciate them. And as we've said on multiple occasions, the rationale for doing this evaluation now, even given the evidence that's been generated to date, is that decision makers, including patients and clinicians, have to make decisions now. So we are trying to inform those decisions the best way we can, recognizing that more data will be generated moving forward.
Thank you. Mr. Paul.
Good morning. Tesaro thanks ICER for the opportunity to comment. Tesaro is a biopharmaceutical company devoted to providing transformative therapies to people facing cancer. I speak on behalf of my colleagues who, in partnership with physicians, patients, and their families, worked over many years to bring niraparib to women with recurrent ovarian cancer. We support discussions of value for new therapies. With transparency and clarity for patients, payers, and providers in mind, Tesaro has a number of comments about ICER's methodology and conclusions. Patients with recurrent ovarian cancer who are in response to platinum-based chemotherapy have limited treatment options. Before niraparib was available, the standard of care for these patients was observation or watch and wait. In clinical trials, patients who did not receive active treatment after response to chemotherapy had a median time to recurrence of 4 to 6 months. Recurrence generally triggers another round of chemotherapy with associated toxicities. Niraparib was studied in the robust, double-blind, randomized controlled global phase 3 trial called NOVA that prospectively determined patients' germline BRCA mutation status. Depending on mutation status, patients were assigned to one of 2 independent cohorts and were randomized to niraparib or control within each cohort. The trial was conducted with the highest level of rigor, and the study results have been published in the New England Journal of Medicine. In the NOVA trial, patients treated with niraparib had significantly longer progression-free survival compared to control, regardless of BRCA mutation status. Among patients who were germline BRCA mutation carriers, 62% of those who received niraparib were progression-free at 1 year, versus 16% for control. Among those who were not germline BRCA mutation carriers, 41% of those treated with niraparib were progression-free at 1 year, compared to 14% in the control group. The PFS curves remain well separated through the entire observation period, indicating the long-term benefit of niraparib treatment. In patients who are homologous recombination deficiency negative, the group theoretically least sensitive to PARP inhibition, 20% had sustained benefit lasting longer than 18 months, nearly 3 times the rate of control. This represents a meaningful benefit to patients when the consequence of progression is another round of chemotherapy. These data demonstrate that niraparib provides a significant benefit regardless of biomarker status. We have significant concerns regarding the cost-effectiveness modeling that forms the basis of ICER's value assessment. The results of the cost-effectiveness assessment conducted by ICER are almost entirely dependent on the overall survival data. However, as the OS data from the NOVA trial are not yet mature, the ICER model used an assumed OS for niraparib derived from a phase 2 trial of a different drug. Tesaro has additional concerns regarding the modeling approach. For example, ICER seems to have applied a ratio of median OS to median PFS to extrapolate OS data from a different drug to niraparib. However, cost-effectiveness modeling requires the use of means rather than medians. When Tesaro applied the ratio of means to calibrate, the cost-effectiveness ratios for niraparib versus surveillance fell within the acceptable thresholds. The fact is that all these estimates are based on assumptions, and we will not know the true cost-effectiveness ratio as calculated using ICER's approach until the OS data are mature. Tesaro believes that this is a fundamental limitation of the analytical approach. The fact that a therapy that more than doubled the proportion of patients who were progression-free at 12 and 18 months and has been included in NCCN guidelines would be deemed not to be cost-effective regardless of price shows the limitations of the approach. Many new promising oncology therapies are on the horizon, which, like niraparib, have the potential to transform the treatment paradigm of many cancers. Many of them will be approved based on PFS or overall response rate with immature survival data. As noted in the paper by Broglio and Berry, thousands of patients may be needed to adequately power a study for OS as the duration of post-progression survival increases. Hence, it may not be feasible to adequately power studies for OS for many new therapies. Tesaro does not believe that assessing the value of these therapies based on OS assumptions not founded in sound evidence will be helpful to advance the value conversation. We believe a fundamentally new approach is needed to appropriately value endpoints such as PFS and ORR in cancer. We plan to actively engage with the oncology community to advance this discussion. Tesaro is committed to delivering transformative and value-added cancer therapies to patients, physicians, and the health system. Thank you for the opportunity to come.
Thank you very much. Kind of go to our ICER team if you have any questions or comments.
Yeah, thank you for your comments on, especially the modeling analyses. We did obviously address some of your concerns with the connection between PFS and OS. We did actually calibrate the model and adjust so that we increased overall survival, specifically for niraparib. Second, we don't compare niraparib to the other PARP inhibitors, so it's only within one comparison. So the idea is in cost-effectiveness modeling to set similar in treatment populations in terms of their survival. The only difference would be a marker such as progression-free survival or the treatment in some cases. So that in a sense limited our comparison, which also helps produce those cost-effectiveness estimates. Until overall survival data are published, we're left with making assumptions which we clearly acknowledge in our report, in the presentation as well. And the other comment that I'd like to respond to is some type of cost per progression-free survival is a very difficult estimate to interpret. And if you're going to move in the direction of cost per progression-free life years saved, we have no way to compare that to any other types of disease states or any other types of treatments. Therefore, it's very difficult to estimate that as an endpoint. And so I would be, it's pretty challenging to interpret that estimate. So thank you for your comments.
Are there any thoughts or comments from the CEPAC members regarding the manufacturer's remarks?
Eric, I have a question.
Yes.
Can you remind the council what is the FDA requirement for follow-on studies for the drugs at this time? So basically, we've been talking about not having the OS data yet. What studies do you have in the field? I forget which the FDA have required you to do following approval. Can you summarize that for the?
Yeah, so first of all, I'm not a regulatory expert, but there's no specific clinical study. We will be following the NOVA study to get overall survival from that trial. But, events have to accrue for us to be able to estimate it, so that's going to take some time.
Don.
Dr. Book.
Respond. Just to say that the model is, for all the comparisons, is updatable. This evidence is currently what we have and currently how we can estimate life years gained and quality adjusted life years gained. So any additional overall survival evidence can easily be incorporated in the model with estimates updated. So.
Yeah, just a biologic question for Dr. Bala regarding what appears to be the effect on the bone marrow of your drug. I know literally nothing about the biology of the drug with respect to that, but why is it that that's substantially higher than some of the other agents?
Yeah, so I'm not sure
I'm concerned about that.
Yeah, so I'm not sure I have a clear answer to say this is the reason why we see any of the toxicities that we do. We are looking at what is the potential mechanistic reason that might be, driving some of those. So I don't think we have a clear answer to give you today on that. That's something that we are looking at.
question for, Rena, I'm sorry, and then we'll go to Dan.
Since both of your presentations were focused on the patient, can you please describe in some detail the extent of the patient assistance programs you have put in place for ensuring access to this therapy for patients who have significant financial toxicity associated with their use?
Yeah, so I'm happy to go first. We have a patient assistance program called Together with Tesaro, which provides patients who cannot afford the drug access to free drug. And there's a significant proportion of patients who are getting niraparib through that program.
Do you have a sense of the share?
I'm not sure I can give you the actual percent of patients who are on it, but I know that it's significant. But I can kind of try and find that out.
Does that program have income thresholds that patients must meet?
It does, but it's a fairly generous income threshold.
Thank you.
From an AstraZeneca perspective, I have Ellen Capolino, our Director of Market Access, who can provide you answers.
That's fine, yeah.
Yeah, Ellen Capolino, Senior Director of Market Access at AZ. Similarly, we have a program called Access 360 that helps patients navigate and understand what their insurance is, and then it also helps them get to resources that they might be qualified for.
That's great.
And
Thank
again,
you.
does that program have both income threshold and also insurance provision requirements?
Yes, it does. So it's standard in the industry.
And what are they?
So it's we do have those. It's something that's done across the industry.
What is the income and what is the?
I don't have those thresholds on me.
But I think this is a great question. Maybe we can get some of that data for the policy roundtable this afternoon and come back to that one. Would that be okay? Thank you. Dan.
Just a question for Mohan. So you mentioned that you found markedly different results when you used means for progression-free and overall survival. We're not aware of any publicly available source that has sufficient data to generate means, so I'm not sure where the information came from.
If you use study 19 and you use the same extrapolated curves, you can estimate the mean OS as well as the mean PFS. And if you use that ratio of the means to calibrate, you get a very different estimate.
All right. Anything else from our ICER team? Comments, questions? Okay, great. Thank you very much for your remarks and your answers to questions, and for the comments from everybody else as well. So that brings us to about 11:40 or so. I'm looking for my agenda. Right. So we'll move into sort of the public comment process at this particular time. Thank you. So the order of public comment will go like this, but we'll start with Lisa Schlager, I'm sorry if I mispronounced your name, from Force, and then Sienna, and then Chad and Jill will follow them. But if you can. Sure. That'd be fine, yeah, thank you. I don't have name tags for you, but.
Should we all come up?
Yeah, that would be fine. If you can all come up, that would be great. We'll call an audible here. I'm happy to do that. So the format's, for those in the audience, format's similar. Each commenter will have about 5 minutes. We'll keep time and try not to beep you off the stage. But then we'll also have, make sure that prior to each comment, you introduce yourselves and note if there are any conflicts. Or we note the conflicts that we have projected on the screen behind you, I believe, for each person. So you don't have to spend your time talking about those, but if they look incorrect, we can clarify those now or later. And then we'll just kind of do the same thing if there's questions as well. So thank you very much, Lisa.
Thank you. So yes, that is accurate. That's the information we provided. The program support that we receive is to help our education and support programs, just like most nonprofits receive. So my name is Lisa Schlager, and I'm the Vice President of Community Affairs and Public Policy for FORCE, also known as Facing Our Risk of Cancer Empowered. FORCE is the only national nonprofit organization which serves all individuals affected by hereditary breast and ovarian cancer and the related cancers.
So we deal a lot with BRCA mutation carriers and folks that are diagnosed with other hereditary cancer syndromes. We've been providing support and advocacy and education and research to this community for about 20 years. Women with BRCA mutations, like myself, face some of the highest known ovarian cancer risks of any population. And our cancers often develop younger, they're more aggressive, and they affect multiple family members. So this is a really heavy burden on our families. And we also deal with the fact that these mutations are potentially passed down to our children. As an organization, FORCE has grave concerns about the conclusions that are drawn by this report. There are significant differences in the key populations of interest, which are described on page 3, and the patient populations used for the comparative data. The studies chosen as comparators were not equivalent to the stated PARP patient populations in terms of the number of prior treatments, platinum sensitivity, or BRCA mutation status, and as such, it's not really possible to draw accurate conclusions on clinical effectiveness. The report's economic analysis has noteworthy omissions. Some of the assumptions used to develop the cost models are questionable, leading us to have concerns about the accuracy of the resulting conclusions. These include less than comprehensive cost estimates for grade 3 and 4 adverse events, managing side effects other than the worst adverse events, platinum regimen reactions, infusion administration, which has been noted, and bowel perforation and arterial thrombotic events associated with Avastin. The analysis also fails to account for lost productivity resulting from the side effects that patients experience, especially with commonly or traditional therapies. Detailed information about these gaps was provided in our written comments submitted in August. As noted at the opening, PARP inhibitors represent a decade-long research investment with tens of thousands of people taking the risk to volunteer for studies. And while these agents may appear costly on an individual scale, there are significant societal benefits given the investment in development, the savings in productivity, and improved quality of life, as well as the potential for further improvement in this therapeutic approach by using agents at an earlier stage. In not performing a societal analysis, ICER missed the opportunity to capture the value of these agents to patients, families, and society, especially in the hereditary cancer community. The median age of those included in the PARP studies ranged from 57 to 62 years old, meaning that more than half were likely younger and were working and caring for children. In our community, people have noted fewer interruptions of daily living activities and higher quality of life with PARP inhibitors as compared to chemotherapy. These are real costs that are shouldered by patients and their families that should have equal consideration to the costs borne by the payers. While ICER claims that the value framework is deeply patient-centered, we struggle to find the patient-centeredness in the process or the report's conclusion. The brief section of insights gained from discussions with patients and patients groups seems to be lacking, with little or no insight into the value of the availability of new non-chemotherapy treatment options such as PARP inhibitors. We respectfully submit that this analysis and report is extremely premature. There's simply not enough data, the conclusions drawn are misleading, and the publication of this report is going to harm ovarian cancer patients. It's likely to be used to drive practice and as well as restricting coverage and access through negative coverage decisions. We urge you to reconsider your decision to finalize this report and appeal to you who are voting members to reserve approval because this is premature. If ICER finalizes this report, it will do a grave disservice to the ovarian cancer patient community. The head-to-head studies that you call for will cost us many more years and lives and are likely to take a long time to complete. The data from these studies will take years to mature, in part because so many are doing well on these therapies. In the meantime, restricting coverage and reimbursement will set back progress and send a discouraging message to scientists, patients, and families. So we urge you to not approve this report at this time. Thank you.
Thank you very much. Do we have any comments or questions from the ICER team?
Yes, on the economic model, the side effects that you noted, we actually did include and were varied. The costs were varied all the way from essentially an outpatient visit up to an inpatient visit. So those costs were actually included. In terms of lost productivity, I don't think anyone's denying that lost productivity could be significant. However, there are no data on this. At the age group within ovarian cancer, we found very, very little data. And as well as patient-centeredness, in a lot of ways, the quality adjusted life here in terms of where those estimates came from were directly filled out by patients. So there are some estimates that do involve patient-centeredness within the economic model. Thank you.
My name is Shauna Rubinek.
I'm sorry.
And it's okay.
Sorry, Ms.
And I am living with ovarian cancer. How much is your time worth? I'm not referring that time is money. I'm talking about time equals memories. I carry the BRCA1 gene mutation, so when I was 43 years old, I chose to have surgery to reduce my risk of ovarian cancer. When I woke up, I learned that I had it instead. Less than half of all women diagnosed with ovarian cancer survive 5 years. In fact, my cancer was advanced, so statistics indicated that it was not likely that I would live long enough to see my son graduate from high school. Time was now front and center in my world. I was in it to win it, though, and began IV chemotherapy. At that time, that was the only option, so I drove 2 hours each way for weekly IV treatment for 18 straight weeks, which meant taking unpaid time off of work, additional cost in gasoline, wear and tear on my vehicle, and someone else needed to go with me who needed to take time off of work because of the possible side effects. As those 4.5 months of weekly treatment went on, I felt like time was slipping away and life was passing me by because I had very little energy to go to my son's events at school or to even have lunch with my friends. The recurrence rate is high, so I have watched many women travel this journey of one chemotherapy regimen after another, and when one stops working, another is introduced until there are no other available drugs. I was well on my way with this journey because during my second recurrence, IV chemotherapy stopped working. I was then eligible for olaparib. I knew that the average progression-free survival was several months. I also knew that some women had had a complete response and were in remission. I weighed the potential side effects, which were no different than IV therapy, and for a lot of women in the clinical trials, they were less severe. I'd already had 3 previous lines of therapy, and my cancer was no longer responding to treatment. So for me, living a few more months, but hopefully longer, was worth it, because I wanted to see my son graduate from high school. Taking olaparib at home gave me time again. I was able to go to work each day, take care of my son. I didn't need the steroids or anti-nausea medicine. The side effects were minimal compared to what I had experienced on IV therapy. This new therapy was a game changer for me and for my quality of life. I was able to spend time with family and friends, and you know what? I got to see him graduate from high school, and I got to take my son to college. Although my cancer initially responded very well, it eventually proved to be one that progressed after several months. No, I didn't achieve remission, but what olaparib gave me was time to witness and participate in life events that I would not have seen had I not tried it. The financial cost of PARP inhibitors is high for many reasons, but there's no way to put a price on the hope that they bring to women like me. If you were facing such a diagnosis, how much would you pay to live long enough to see your child graduate from high school or college or get married or have his or her own children? Teal is the awareness color for ovarian cancer survivors. A friend and fellow ovarian cancer survivor once said, there are 50 shades of teal, meaning that no 2 ovarian cancers are the same. Survival statistics haven't changed much in the last 45 years, so we need to have as many treatment options as possible so that more women survive than die from ovarian cancer. We are more than statistics. We are your mom. We are your BFF. We are your child's favorite teacher. We are your favorite boss and your loyal employee. We tend to be the caretakers of our families. I have learned that I'm now facing my third recurrence. It's possible that I will not see my son graduate from college or get married. I ask that while you are considering the cost effectiveness of PARP inhibitors, you strongly consider the time and quality of our lives in the setting of a disease that robs us of so much. Thank you.
Thank you very much. Any questions or comments? Thank you for those comments. Both your comments and the comments from our other patient representatives are very compelling. I do want to address, I guess, some of the earlier comments around ICER's perceptions of ICER as not a patient-centered organization or one that conducts their evaluations without considering patient-centeredness. I think that we feel that we've taken a lot of steps to more fully engage with the patient community. We've heard a lot of feedback from individual patients and from patient groups during the construct of this report. I do have to say, these are, again, very elegant statements and comments, but we have heard from women who are weighing decisions, particularly in the maintenance setting, around the possibility of somewhat of an extension on progression-free survival against the toxicities they'd experience on active treatment versus observation as a previous standard. So we have heard, as Lipika mentioned, a variety of opinions, and we wanted to try to fully reflect them in the report. I'd also say that these therapies do have the potential promise of improving the productivity possibilities for women, as well as their quality of life. But as an evidence-based organization, we want to see evidence of that information, and that's what we're looking for in the data presented to us at this time.
Can we ask a question?
Sure.
And forgive me if I'm speaking out of place, but given the lack of data, why are we doing this right now? I keep hearing we don't have the data, we don't have the data, we don't have the data. So why are we in such a rush to put out a report when we are lacking so much information?
Steve or Dan? Well, and we can also hear from others as well, but I would say clinicians need to know who to prescribe these drugs to. Patients need to understand the balance of risks, benefits, and other trade-offs. And payers need the information to understand whether there are particular criteria that they should apply for who should use the medications. And the drugs are approved, so this is the time for those decisions to be made, even in the absence of data. Andrea or Matthew, do you have anything you'd like to add into that?
Yeah, I mean, I think as a clinician, and I also sit on the NCCN panel that helps guide other clinicians as we put our levels of evidence box. This is helpful. I hope it won't be completely restrictive for our ability to give these drugs. There are some payers that will use these such reports to say, no, it's not within our guidelines or it's not part of your policy, and that's really our concern. We've had the luxury of allowing a lot of patients to be on clinical trials when that's happened, but as we get further down and that may not be there in the future. I wanted to comment in relation to all this. One was about the toxicity. And I think it's a misnomer when you look at the table of toxicity for PARP inhibitors. I think Don asked about why is the one drug so much more toxic. Once patients get on their dose, they have much less toxicity than those tables would show us. And I think that's all of us should keep that in mind, that their first cycle or second cycle toxicity isn't what they're on 6, 7, 8, 10 months later. They're on a stable dose, they're feeling well, they're doing well. So that toxicity kind of goes away. So I would argue that what Don's point about niraparib having a high toxicity, because it's too high a dose. Most patients aren't on that dose.
Is it maintenance phase specifically? Is that,
well, it's not necessarily maintenance versus treatment.
Okay.
All these drugs, when you give too much of it, they have toxicity. Once you get the patient on the right dose, they tend to have a much better toxicity profile. And I think separating that out is a little bit tricky if you're not seeing these patients and treating them. It's not like standard chemo, where over time they start getting worse thrombocytopenia, over time they get worse anemia. Now you see some of that, but most of this is a dose effect. Once you get patients on the right dose, they do pretty darn well as far as toxicity. I don't know if that'd be your...
Thanks.
Yeah, I would agree. I would say, we've been fortunate enough to have the PARP inhibitors in the clinical trials where cost has not been an issue. And we've seen some really great responses. We've seen good patient tolerability, and like Dr. Powell had mentioned, once you get a dose that really works for the patient, you can continue on it without significant difficulty. So again, coming from someone who, from a medical standpoint, I'm very excited about PARP inhibitors. I think looking at the maintenance therapy right now is very difficult because I think there is a stratification in terms of who is going to do well and who has the best potential response. So, there are the three classifications of the BRCA, the HRD positive, and the none. And so I think it's very difficult to compare that all as one group because the responses are
so different. Yeah, that's great. I'd like to move on to our next two folks with comments, if we could.
Sure. Thank you. My name is Chad Ramsey. I'm Vice President of Policy for Ovarian Cancer Research Fund Alliance. We're the largest global nonprofit organization dedicated to fighting ovarian cancer. OCRFA advances research, supports women and their families, and works with governments to ensure ovarian cancer is a priority. We appreciate the opportunity to submit comments on this report. As a patient-facing organization, one of our primary concerns is that patients are able to access medication when they and their physicians feel they're appropriate based on the medical evidence, and the innovation in ovarian cancer drug development can continue to thrive. I also just missed a sentence, so I'm going to go back. Able to access medication when they and their physicians feel that they are appropriate based on medical evidence, and that innovation in ovarian cancer drug development can continue to thrive. To that end, we have some specific concerns about the conclusions of this report and about the potentially negative impact that premature timing of this analysis could potentially bring forth. Our concerns are really about three main areas: the timing of the analysis, its impact on innovation, and threats to availability. Conversations with patients and clinical experts revealed a common thread, and we heard it today. The publication of this report is premature. PARP inhibitors represent a brand new class of medicine for ovarian cancer patients, many of whom face multiple reoccurrences, have few effective therapeutic options, and will unfortunately eventually die of their cancer. As they are still in their infancy with respect to clinical use, particularly rucaparib and niraparib, which were just approved this past year, trials of PARPs are ongoing and additional research is yet to be completed. As the report acknowledges, no overall survival data yet exists and probably won't for a few years. In spite of this, the report makes assumptions in an attempt to fill in the gaps. These assumptions are a poor substitute for actual data. Furthermore, as the data also acknowledges, the lack of comparative trials among these three drugs make it impossible to truly compare them. We all know the problems with comparing apples to oranges. We are well aware that the financial strain of treatment can be very significant to patients. The issue of financial toxicity is a very real one for our patients. It's something we're working on every day, as Susan mentioned. New therapies don't do our patients any good if they can't afford them. We recognize, however, that the research and development done by these companies in the development of PARP inhibitors represents a massive investment of financial resources, and new therapies are often going to cost more than standard of care treatment. PARP inhibitors hold great promise for ovarian cancer patients, and we need the industry to continue to invest in their development. We are concerned that this report could lead to devaluation of this breakthrough class of drugs and could have a chilling effect on innovation in cancer, so desperately in need of more research. The report includes a comment that was taken from the olaparib ODAC meeting. The quote is, "If you're going to pay the penalty in terms of toxicity, then you want return on that, not just that your progression is delayed, but that your overall survival was beneficial." The statement does not reflect the opinion and value calculation made by many survivors and their physicians, as you've heard. We all would like to see gains in overall survival with new treatments, but for those dealing with chronic non-curable diseases, progression-free survival is very important. This is especially relevant with PARP inhibitors, which are frequently well tolerated and offer most patients good quality of life. Ovarian cancer patients and their physicians think about the value treatment in nuanced ways. Despite its intended use, we fear that the data in this report will be used by payers to deny patients access to these anti-cancer medicines. when those treatment decisions should instead be made by patients and their doctors. Just yesterday, I sat in a briefing in the U.S. Senate as an ovarian cancer patient explained how she had to seek out a PARP trial, ultimately flying thousands of miles to complete her treatments. The fact that she was able to extend her life and see her daughter walk across the stage at Duke at the graduation ceremony was certainly a critical benefit for her. We encourage this body to consider the needs of patients facing this terrible disease and the challenges patients and their physicians face when considering treatment options. It is essential that patients and physicians have access to all of the PARP inhibitors revealed in this report. Policies that increase access to new therapies and encourage private sector innovation are essential. As it's clear that the coming years will offer more data to evaluate the clinical and cost effectiveness of these drugs, we strongly urge ICER to consider updating this assessment in the future as more data becomes available. On behalf of OCRFA, thank you for your consideration and allowing us to make these comments.
Any comments or questions from Steve or Dan?
I just mentioned, I should have mentioned this before, but ICER has just published its first new evidence update for another clinical topic recently, and so expect to see more new evidence updates in further topics moving forward, including this one.
Thank you. A quick thing about prematurity. I mean, some patient organizations come at this from a different perspective, and they just get bothered year after year when the evidence available to them and to their clinicians at the time of FDA approval or even shortly thereafter is wanting for them. And so we understand that your job is to push in a lot of different directions at the same time, which is always challenging. But if we weren't here today, none of this were to happen. United Healthcare, Anthem, Express Scripts, CVS, they'd all be in a room somewhere making decisions about these drugs. Those decisions are going to include considerations of clinical effectiveness and cost. Wouldn't we rather have that process include an independent look at the evidence, a public meeting, engagement with you all and others over an 8-month time course in which a lot of people have tried their best to try to be fair with the evidence, hear different perspectives. I just don't see how that's worse than the course that has been the norm in our healthcare system. Every other country, developed country, has a public process in which these issues are debated except for the United States. So we are trying to bring some of that into the public domain. We definitely want to be transparent about the lack of certainty and the need to continue to look at evidence as it progresses. But I also think the patient community can be a really strong advocate to have better evidence, to push for that evidence to be discussed publicly, and to weave in some of the concerns about access both from the insurance side and the cost side that we think is so critical to moving our country forward in this way. So your being here today is absolutely critical as part of that, and can't tell you how much we appreciate it. But I hope you also appreciate that we can't wait. We got one article once about another cancer. They said you need to wait 8 to 10 years. Don't even try to talk about the evidence for 8 to 10 years. I think there's a perspective in which today patients and doctors are going to be meeting in some room, and some insurer in some other room is going to be making decisions. So our hope is that we can at least contribute some more light to that process by trying to be as humble as we can and as open as we can about where we are with the evidence today.
I certainly appreciate that, and thank you for allowing us to be a part of this. We all certainly agree that more data is great, and more transparency is terrific, and we appreciate what you're trying to do. I think in this particular case, we're not talking 8 to 10 years, we're talking 8 to 10 months. And so from that perspective, we would just probably prefer to see a little bit more time to let the data mature before moving forward with something like this.
Could I add to what
please, Ryan.
Steve said? Thank you, Eric. I would just add not only evidence, and let me say this panel, and every time we meet, we struggle with this. And it's tough. But at the same time, I agree with Steve just said. I would rather that a group of us sit around this table and do this in a public setting, which is not comfortable all the time, than it's going to happen behind closed doors with other people. The other thing I would just add to what Steve said is, I understand your concerns. We sit here, we hear you. But I so far we talk about the financial toxicity. One of the pharma groups that sat up there had net profits in the U.S. last year of $3 billion. I hear this, oh, they need to be paid for innovation and research. I am a policy wonk. That's what I do. And everything I've read says that by Europe capping pharmaceutical costs does not have effect on European pharmacy innovation and research. At some point, pharma has to take responsibility, and I understand concerns, but when do we go after costs in the U.S. related to pharma? And yes, we're looking at evidence, but we're also looking at cost.
Rachel. Just a quick follow-up. Mr. Ramsey, you said that 8 to 10 months might be an appropriate period, but a number of the pieces of evidence that you suggested ICER should have before making these decisions are not the subject of trials at all right now. So it's not a matter of waiting to update PFS or OS estimates. It's about, so you mentioned head-to-head comparisons of inhibitors. Those are not currently the subject of ongoing clinical trials. Is that correct?
Correct, as far as I know.
Okay, so it would be a much longer period of time that we would have to wait before such trials were initiated, if they are to be initiated at all, right?
Yes.
Okay, thank you.
Yeah, and I agree with you. I didn't suggest 8 to 10 months. I suggested not 8 to 10 months.
All right, I got you. Shumei, do you have a comment real fast?
You know, I just realized pharmaceutical companies are, I think they are currently paying a lot of attention to real-world evidence. So, you know, it sounds, through our clinical experts and the patients, it looks like the real-world setting is quite different from what's in the clinical trials. I can see maybe for the pharmaceutical companies publishing some real high-quality real-world evidence, maybe in the future will be really, really helpful for this kind of a review. Any comments from the ICER group? Do you consider that kind of evidence in the future if they have, or you currently already consider those evidence, but there's no, you know, publications?
Well, from an evidence perspective, we've never considered ourselves purists, so we're not going to just focus on RCTs only. We do look at observational data, but as you can appreciate, in a situation like this where so many drugs are so newly approved, there's very little in the way of real-world evidence at this point. When we do our report updates, if there are real-world evidence studies available to us, then we would include them in our review without question.
Thank you. We're going to come back to Matt, but I really want to make sure that we get to Jill and your comments, and we really appreciate you being here, and I don't want to short you in any way.
They're mostly echoing points that have already been made.
But we will take the echo. So please,
Okay.
please start.
Okay. Good morning. My name is Jill Hildren, and I'm honored to have the opportunity today to add my comments to this discussion on the use of PARP inhibitors. I am a BRCA1 mutation carrier, a survivor of ovarian cancer, and a part of the FORCE community like Lisa. I also have a professional background in public health and understand the need to balance the interests of the individual patient with the interests of the healthcare system as a whole. So as both a patient and a professional, I appreciate ICER's efforts to evaluate therapies for value and cost effectiveness. But I want to spend a few minutes this morning highlighting some concerns regarding this final report on PARP inhibitors that are shared by many of us in the ovarian cancer community. And to echo something that's been said repeatedly, the most fundamental concern we have is that in the report, ICER rightly and repeatedly emphasizes the difficulty of the task of assessing PARP inhibitors for value and cost effectiveness because of both a lack of outcomes data and a lack of reasonable comparator data. And yet, despite that stated data deficit, ICER has finalized a report that will almost certainly end up severely restricting access to medications that thus far appear to play an important and unique role in treating ovarian cancer recurrence. While ICER, in its response to some of our community's comments, states that it would be ethically questionable not to evaluate the comparative effectiveness of these therapies, it's clear to us, the ovarian cancer community, and I would hope to many of you, that what truly is unethical is making assessments that will likely have profound and negative consequences for ovarian cancer patients without having adequate information to do so. A second concern, which has also been brought up many times today, has to do with the assessment in the report of the value or lack thereof of progression-free survival as an outcome. ICER clearly states that it engages patients in the process of considering a drug's value, and of course we appreciate being able to make comments here today, but it has surprised many recurrent ovarian cancer patients like my friend Terry Woodhull and others that the report appears to dismiss PFS as not very important. It's a time when women can work and be productive in other ways that matter to them, spend quality time with the people they love, and because of the greater ease of taking and tolerating PARP inhibitors in this case, it's time when their family and friends are relieved of significant caregiving responsibility. As Terry says, yes, we would all like to live a long time, but once you have recurred, and especially when you have recurred more than once, you realize that it's not like you will be cured. And instead, what becomes important to you, your family, and society at large is the quality of your life. For us, progression-free survival is the most important clinical outcome. And again, that echoes what many others have already said today. Finally, I feel compelled to address ICER's decision to forego performing a societal analysis of lost productivity as a result of limited evidence due to, quote, the typically advanced age and severity of disease in ovarian cancer patients. And this is, personal. As someone with a BRCA mutation, I'd say that the assumptions underlying this decision are at least partially incorrect. And as a result, the omission of a societal analysis results in a serious undervaluing of these therapies. As many of you probably know, or perhaps all of you, in women with germline BRCA mutations, one of the primary populations of focus here, ovarian cancer tends to develop at a considerably younger age than in the general population. In our community, ovarian cancer is frequently a disease of women in their 30s and 40s, and sometimes even 20s when we are immersed in careers, in civic engagement, and often in parenting. I was diagnosed at the age of 44 when my daughter was 8 and my son was 12. I'm currently working with 2 women in their 30s with young children, one of them already recurrent at the age of 34. Terry Woodhull, who was an integral part of preparing these comments, was diagnosed at the age of 47 in the prime of her career in life. We heard from others today who are diagnosed in their early 40s, and I could name dozens more examples like this just from my own experience. But moving from the anecdotal to the data-based, as Lisa already discussed, if you look at the median ages in the studies that were used for this analysis, you can see that a full half of the women in the studies were younger than those median ages of 57 to 62, and that the youngest participants were in their late 20s and early to mid-30s. And I just want to say that these women and the significant loss of literally decades of productivity as workers, as mothers, as spouses and friends and community members, if they're not given effective treatment, should be counted. The fact that they're not in this analysis and that this lost value is not reflected in the cost effectiveness analysis of PARP inhibitors is problematic. I understand that the data is not there, but there needs to be some greater weight to that in looking at the whole cost. I'm probably not out of time because I'm in summary, we strongly believe that this final report should in fact be a preliminary one. While it's an important start to the discussion, its analyses are based on inadequate data, as the authors themselves repeatedly attest, and it also fails to take into consideration a number of important points that I think a more thorough inclusion of patients throughout the process might have elucidated. We're deeply concerned that presenting this report as the final word on the value and cost effectiveness of PARP inhibitors will adversely impact both the ability of very ill women to access life-changing drugs and the ability of the medical and scientific communities to continue to collect data on their effectiveness. On its website, ICER states, ICER listens to patients. We trust that that is true and is reflected in the remaining discussion this afternoon and beyond. Thanks again for this opportunity.
Thank you so much, Jill, for your comments.
Thank you. Eloquent comments all. I hope you will be around for the afternoon because part of our new voting structure includes specific votes on different kinds of what we call other benefits, part of that kind of diagram I put up earlier. And work productivity is part of that consideration. Part of why people around the world actually, and in the US too, wrestle with how best to include productivity in these kinds of analyses is because by doing so, you can systematically benefit treatments for young working adults and disadvantage treatments for instance, people over the age of 65. And so if we were at a panel with people with, pancreatic cancer or some cancer that strikes after age 65, they might feel, again, there's an ethical push-pull around this. So we definitely want to talk about it, and we definitely want to include it when there's evidence and data, that's great. And I hope the discussion this afternoon makes you feel like it's given enough of a highlight, because your being here and the comments have been instrumental. Even when there's not data, we want to talk about it and make sure it's part of our report and part of this discussion. So I hope this afternoon gives you a sense for how we are trying to do that. And we continue to look for feedback after meetings as well to learn how we can do it better.
Just throw in another comment.
Yes, please, Dan.
This is, I guess, from the evidence nerd perspective. Please use your position to push for this information. If the populations in these studies are really of younger working age, there are instruments out there, validated instruments, to collect this information as part of clinical trials. It could have been collected, and it can be collected moving forward. So please push for this.
I would like to
Rena.
follow up on that comment and really commend the ICER folks for convening this difficult conversation, but a very important one. I think all of us have a responsibility to understand what our roles are here. ICER and also the committee members have a role in really being humble about what exactly is it that we're doing and how good is the evidence to support what we are doing, or not. I think the patient community has an incredibly important role to play in both providing feedback to us about the estimates and how important they, and the individual parts of these estimates in reflecting their own experience. But I think you also have a very important role to play in turning back to the manufacturer and say, please provide us data that allows us to, that actually reflects our experience in its totality, both in terms of these clinical benefits, these financial costs, these access issues, these other indirect or direct benefits related to caregiver burden, workplace productivity, et cetera. You guys are the participants in these trials. If the trials had produced evidence that could reflect this totality, then our job and these conversations could be much easier for time.
That's easy.
I'm all new to this, but what I hear is that the ICER report, if it comes out and says these PARP inhibitors are not cost effective according to your analysis, if it puts a damper on research done by drug companies, I could understand that completely, because if I wanted to make a living, I'd concentrate on something where there's already been progress made, where there's underlying research that would support investigation, spending money. Ovarian cancer, there's not been a significant improvement in survival rate for 30 years or so. And it's a particularly difficult cancer because you need to have real specialists in major cancer centers who can distinguish between the different histology of the different types of cancer. The success in treating it depends on whether you're getting surgery by a gynec surgeon with the expertise to do the proper debulking. And that can only be at a major cancer center, because community hospitals, regional hospitals, they don't have the money to draw the gynec surgical experts. It's a rare enough disease that you need to go to somebody who sees a lot of it. And that's a transportation logistical difficulty for a lot of women to get to the major cancer centers. I too drive, I usually leave 2 3/4 hours before my appointment to get to Boston, and then I have the same back. So it's not a great cancer, as everybody knows. It's unique in that it's typically diagnosed in late stage. It has, I guess 86% of women are diagnosed at a regional or distant stage, where there's a 90% chance of recurrence, low 5-year survival rate. It often becomes chronic, which means not just you keep taking chemos, but you have radiation, you have surgeries, and the ovarian cancer community doesn't want to have anyone not recognize that this is a special disease. It's very difficult for ovarian cancer survivors to advocate for money because there's so few of us. And the ones who have advanced cancer all die. So they can't advocate for themselves.
When you have these wonderful patient organizations who I think carry on, that legacy of advocacy, over many years, and we appreciate your comments today. Yeah.
I would just like to quickly address the comments about the clinical trials collecting the data. I have been in 4 clinical trials. Once you're in the trial, you can't get them to change this. But as an advocate in the ovarian cancer community, we are trying to get to the table during the trial design process.
Yes.
So that this kind of data can be collected. So hopefully over time, you will start to see a change. But once the trial is set up, you can't do it.
It's a wonderful, wonderful place to leverage your influence. And I think, Betsy, some of your comments we'll come back to this afternoon during the policy roundtable when we talk about the role of advocacy and changing policy to advantage patients with this condition. So, any other final comments from the ICER team before we wrap up for a second? All right, thanks. So we'll take about a 45-minute break for lunch. And we'll come back and have I think a rich discussion on the votes, starting at about 1 o'clock. At 1 o'clock. Thank you very much.